kick off at Wembley at 2 o'clock. I'm never able to say that again, so I've done that. Today is all about general practice and it's about networks, it's about you, and so this is what it's really about. Over the next 45 minutes, and I'm not speaking for 45 minutes, myself and some of our other colleagues who will be speaking, we'll be taking you through where the CCG has got to from over the last 18 months, what the changes in primary care contracting are going to be from April this year, how the enhanced services funding may or may not change from April 14. What is possible when GPs collaborate and as a community when they work together, what can we actually do? Why the whole practice team, not just GPs, are important as process, practice nurses, practice managers, and receptionists. And really, this entire process is about patients, and to that end, we've got Carmel and Phil Porter, with our two main members, who are going to give us their perspective and keep us firmly grounded in this. And after that, there's lots and lots of time in your networks, because really, this is all about yourselves to think about how we go forward from here. So in what ways is the world changing? The PCTs will be gone by actually, before I start this, there's one thing important I wanted to say is, as you probably know, Ealing CCG is likely to be authorized without any conditions. And what I really want to publicly thank is the entire CCG team, the clinical leads and the management team, who worked incredibly hard over the last 6 months to get us to this place. It's a near perfect result. Probably the best result in North West London and the top 5% in the country. So if the leads could just, and all the management could just stand up, and we could just thank everybody, please, so that they know who they are. I think the amount of work they've done has been absolutely phenomenal with a limited resource, with doing their practice work, and for the staff who've been through an enormous amount of change over the last 18 months. But the change doesn't stop. So the PCTs will be gone by the 31st of March. The CCGs are being authorized, and we will become almost the PCT. So the staff who are here, the people who are here will be part of your team, and you have effectively employed them. So they are your team. There's nobody else to pass the blame to, but it's us now. And Ealing CCG is likely to be authorized without any conditions. So what the role of CCGs, what we'll be doing is we'll be commissioning, and commissioning is perhaps a bit of a red herring word. We'll be helping design some of the services that we need for our patients, and we'll be working with other CCG, the local authority, and with the National Commissioning Board. The National Commissioning Board will be responsible for GP contracts. We, as a CCG, will be responsible to the NCB and will be answerable to them. And the NCB will have a local area team who will be working with very closely. And the NCB will also be very important in specialised commissioning, and in London especially, they'll be having quite a strategic role. So what's the role of CCGs in primary care? In the law, or in the Health and Social Care Act, CCGs have a role in improving the quality of primary care and general practice. And really, we've taken the view that this is really developmental and supportive. And for us, over the next 18 months, this is really important, how we get general practice in the best place to deal with the threats and also avail of the opportunities. CCGs will be able to commission services from GPs, but they have to manage two important things. One, that from April 14, this will be on an NHS contract, not on a LES format. And secondly, that we will need to manage the conflicts of interest which are inherent in the system. So there are two quite fundamental things that we will need to address. Clearly, the health and wellbeing boards are a very important part, and the membership of the health and wellbeing boards, in case people don't know, is ourselves, local authority, the hospital providers, the public, and they will be also overseeing and have scrutiny on what the CCG does. So there are lots of checks and balances in the system and a lot of stakeholders. And because of that, really, for us in Ealing, because we are so unique, so what's so unique about Ealing CCG? We are the largest CCG in North West London, with the third largest in London. We have the second largest number of practices in London, and Ealing residents are unique. We use every single provider in North West London, so it's not just one provider. So for us, actually, collaboration and working together is the only way we're going to make this work working with our other CCGs, working together as primary care. For us, really, collaboration is going to be fundamentally important. So, what has been our plan for the next 3 years, or what we've outlined, what we put forward to the National Commissioning Board? The needs of our population cover really these sort of three areas. None of this is new to any one of us. 0 to 5 early intervention, long-term conditions. We're well aware of the burden that we have in Ealing. Alcohol Ealing still remains as the 5th largest highest in London, where the A&E attendances are alcohol related. We're all looking for coordinated care. We know there's been an element of fragmentation and how do we put it together. And even though it's not comfortable to hear it, our resources are finite. The money we have is finite, and there's nothing we can do about it. The four pillars, which is going to allow us, that we've thought that would allow us to deliver the right care, the right place, the right time, cover really 4 important areas. One, there is an out-of-hospital strategy which we brought to you on several occasions and which you have all signed off, which covers the 2 important areas of urgent care, planned care, and how we deal with that responsibly and in a planned way. The second important thing is that we know that to improve outcomes, clinical outcomes now, we're going to have to think about centralizing certain services, localizing where we can, integrating where we can, and that's where the reconfiguration of the acute providers comes into it. And I know that's been a huge dominant theme even over the last 12 months, and we will need to address that. To deliver out-of-hospital care, we've got 80 practices. Each one of us can't be doing everything all the time. We're going to have to think of how we come together in networks, and we've already done that with the ICP. So for people who don't know, we are in 7 networks, serving a population of 50 to 60,000 and working across 9 to 15 practices. Can we do out-of-hospital without working with local authority? No, we can't. It's an absolutely integration of the services, and the evidence of that is working with ICE, with the Children's Nursing Services, and with the ICP. So those really are the 4 pillars of how we're going to be able to deliver to improve health outcomes for our patients. I'm going to take a minute to talk about the money. So what's our budget, our commissioning budget? So Ealing CCG has a budget of 481 billion to buy services on behalf of Ealing residents. Some of you may know that over the last 3-4 years, we've been living beyond our means, and we've got to get ourselves back into balance, because we can't, as a statutory body, continue to be overspent or stay out of budget. So we've got a recovery plan. We're looking at various things and how we can get things back. But also, just as with every other NHS organisation in the country, we're going to have to save some money. And that's got the word QUIP, which I know brings a smile or cynicism to each one of us in different measure. But over the next 3 years, we've got to find ways of how we are going to be spending. Our QUIP challenge in the next 3 years is about 50 million. So we've got to find ways of being able to design and provide services and being able to save that sort of money. So it is a huge challenge, and it really covers every aspect: urgent care, scheduled care, integrated care. It goes across everything. And Jo and her team and all your clinical needs are going through and asking actually how can we do things differently. But what we do know is that as part of the acute reconfiguration and shaping a healthy future, we do have the opportunity in Ealing to invest 9 to 11 million in out-of-hospital services. So I guess the 3 numbers that I want you to focus on is the big number, about $500 million, the QUIP challenge of 50 million, and the potential for investment of 9 to 11 million. And then all this has been going on, but there's been a lot of work going on the side. These really are our building blocks. I put my hands up and say it's not all joined up, and not one service leads to the other streamlined for the patient as we'd like it to be. But the building blocks are there. We started to lay it down. Some of you are using some of these, not some of the other ones. The anticoagulation service, we never thought we'd get it off the ground in networks, but we have done. The diabetes has taken off. I know the referral facilitation causes some anxiety, but that's starting to be bedded down. We've already started working in our networks, and the IT strategy is well underway. So the objective is that over the next 3 years, we get the out-of-hospital matrix delivery joined up properly. Having said that, this is certainly my day, every day general practice looks like, and I don't know what you feel like, but it kind of feels one is just sinking most of the time with the amount of change that is coming, not just in our day-to-day job, but with everything else that's going on. And quite on the weekend I say, you know, okay, we're going to try and catch up, come back on Monday morning and something else has changed. And ask yourself, actually, what am I trying to catch up with? It's a bit like a catch-22. And the question is, you know, if we carry on doing it the same way, will we catch up? Will we be able to carry on doing what we are doing? And most GPs provide an A1 service to all their patients. And the question then, why should I bother? Actually, this is not about me. I never wanted to do commissioning. Why is this all about me? Well, even when you come to general practice, with the amount of change that's happening, even if you're on the right track, doing all the right things, it feels a bit like that you're just going to get run over by the amount of things that are changing going forward. So the question for us as a CCG is, what is our primary care strategy? What are we going to be able to do as a leadership to support primary care to be in the best place? As you know, we're doing in the States, and there's some of the challenges, some of the stuff that we've already done. We've started in the States in workforce review. Some of you have signed up for the estates review, some others haven't. If you haven't, please do. It's now the LMC have agreed that it's fine to go ahead and do that. So please do. It will only help you in your own practice, and it'll also help the CCG to start to develop a business plan to seek investment. And I've talked about pediatric phlebotomy, peer review, referral facilitation, and I believe yesterday was a really good educational event on CKD, but unfortunately I couldn't attend. But there are further challenges. The question is, how do we identify more services that we can that we can deliver out of hospital? We know in Ealing, we spend more money in acute sector than we do in community services compared to similar CCGs in exactly the same population, same demographics, same deprivation, same health needs. So therefore we have less money to spend in hospital care. How do we redress that balance? Can we do it as individual practice? If not, if we're going to come together in networks, what is the CCG and do we need to do to come together in those networks? The issue of enhanced services and the funding around that, how that is going to change, and how can the CCG work with the LMC to bring training into practices, to look at the AQP model. So there's all the kind of things that we are thinking about. I don't know how many of you had the chance to look at the GP outcomes framework on the My Health website. It starts to put together, or starts to pull together, how outcomes in primary care can be measured, whatever that, however we might question how validated that data is. Whether the NCB will look at that data to look at primary care performance, we don't know whether it will look at that tool or some other tool, but we know it will look at some tool. So the question is, how do we support practices to get to the best place? Because this next 15 months is absolutely critical for us. So therefore today really is about us working together in networks, and something about not merging but actually co-producing to work better. And as Dennis put it in his words stuck in my brain, Dennis, wherever he is, that actually general practice is the glue which holds all this together. And really, most of us do a really good job. And how do we move on from here? Can we build on the relationships on the ICP, on the anticoagulation? What else can we do? How can we use our practice team differently? The world of general practice is changing, and how do we respond to that? And actually, how we respond as primary care and general practice also dictates on how we commission the services we need to support us and our patients when we need to refer them on to the next service. So I'm going to hand over to Adam in a minute to give us the LMC perspective, and then we'll have 4 more speakers, and then lots of time for breakouts. So really this is all about us thinking about what can we do differently to become the matrix and part of the delivery of out-of-hospital care, which we will share with our other community providers, but how does general practice want to respond? Thank you for listening.